Okay,
Hi.
thanks, Sam. All right. Hi, everyone. My name is Becca Lang. I'm a pharmacist at the Minnesota Poison Control System, located at Hennepin Healthcare in Minneapolis, Minnesota. And today I'm going to talk about drugs of abuse. I will outline the mechanism of toxicity, the clinical manifestations of overdose, and monitoring management and antidote use for opioids, sympathomimetics, cannabinoids, and hallucinogens. I'll identify the scenarios in which a urine drug screen may be helpful in assessing your patient. And then hopefully by the end of this, you'll be able to recognize toxidromes for these drugs of abuse to apply treatment strategies, which is really helpful, especially when you don't have a clear history of what the patient did prior to coming in. I have no conflicts of interest to disclose. So just a little background on the Poison Center if you're not familiar. So we're located in Minnesota, like I mentioned. The 1-800 number that you call is a national number, but Poison Centers are regional. So at our center, we take calls from the whole state of Minnesota, South Dakota, and North Dakota. We're staffed 24/7. We're covered under HIPAA, and our service is completely free of charge. We're mostly staffed by pharmacists, and we end up taking a certification exam to become a certified specialist in poison information usually after our first year working full-time for the Poison Center. I'm going to use the word toxidromes in this talk today, so just wanted to define it first. A toxidrome is a constellation of findings either from the physical exam or from ancillary testing, so physical exam, vital signs, which may result from any particular poison. First, I'm going to just review some basic concepts about urine drug screens before we jump into the different classes of drugs of abuse. Commonly at the Poison Center, we're asked about helping in interpreting a urine drug screen results, or even if one is appropriate to obtain in a certain scenario. The two most commonly used urine drug screens are immunoassays and chromatography with mass spectrometry. So I'm just going to go over the basics of these two types of tests. So immunoassays are also known as ELISAs. A common example of an ELISA is a pregnancy test. So most people are familiar with that. So this is an enzyme-linked immunosorbent assay where you have an antibody absorbed on a solid surface. So when we're testing for drugs, the urine sample and drug or metabolite is labeled with an enzyme and added to a testing well, where drug in the sample and drug labeled with the enzyme compete for binding sites on the antibody that's on the surface of the well. And then the unbound components are washed away and a reagent is added. So that results in a colored byproduct that's formed, and it reacts with the drug labeled with the enzyme that's bound to the antibody. So the reading that we get is inversely proportional to the concentration of drug or metabolite in the urine sample. So most hospitals can only perform immunoassays on site. The good thing is these are drug screens that are pretty fast to get results. They're inexpensive, but the downsides are can be a lot of false positive and negatives. And we get false positives when a drug cross-reacts with an immunoassay due to similarities in structure. And then false negatives can happen for a variety of reasons. So when the concentration is below the threshold of detection, if the urine sample is tampered with somehow, it also only can detect recent use. So we have to consider the time between the exposure to the drug and when the urine sample is being obtained. And then when a specific drug in a class has a very different structure than the compound it is meant to detect, we can get false negatives within the same class of drugs. A little bit more reliable of a test, or what we could consider a confirmatory test, would be chromatography with mass spectrometry. So chromatography is when we separate compounds in the sample, and then those are fed into the mass spectrometer. The compounds are ionized and detected with mass to charge ratios to identify distinct compounds. So versus getting a category that's positive or negative, we're getting actual drug or metabolite results. So this is important to note, this only identifies compounds that are in the database for the lab performing the test. So these databases can be pretty robust. We actually have a toxicology lab at Hennepin Healthcare, and it tests for over 1,000 different compounds. So it's a pretty big database, but just, of course, this won't identify or pick up any emerging drug of abuse or novel drug of abuse. It needs to be in the database already. So this is going to be more reliable. You'll pick up drugs missed by an immunoassay, but of course, with a better, more sensitive and specific test comes the cons of taking longer to get results, especially, you know, like I said, a lot of hospitals don't have this on site. So this might be a send out lab where it might take, you know, even several days to get the results. So definitely not clinically useful in any way, but can be just more confirmatory of what happened. And then more expensive. So definitely some downsides there. So just to recap, comparing the two, so immunoassay is readily available. They're pretty inexpensive. You'll get results pretty quickly. Confirmatory testing with chromatography and mass spec, more expensive. It'll likely be a send out, but you'll detect drugs at lower cutoff limits. It's, you know, you're going to get specific drugs and metabolites versus just general categories. And then in some cases too, chromatography can be quantitative, which can be really helpful. So given all these limitations, when would you consider ordering a urine drug screen? So some specific instances, if there's a patient that comes in with a new onset psychosis, a first time seizure, a child with a apparent life-threatening event, a patient that has an undifferentiated altered mental status with no history and kind of a broad differential that is being worked up. Typically, inpatient mental health centers will want urine drug screens on patients being admitted. And then other things like if there's a concern for Munchausen's by proxy or CPS involvement, this can be helpful for investigations that they might do, you know, down the line. The first class of drugs I'm going to talk about are opioids. So what's the difference between an opiate and an opioid? So an opiate is an alkaloid that is naturally derived from the opium poppy. So falling into this category are morphine and codeine. And then opioids are any compound that exert an effect at the opioid receptor. So this includes all of our semi-synthetic and synthetic drugs. So examples of semi-synthetic drugs are hydrocodone, hydromorphone, heroin, and then our fully synthetic opioids are fentanyl, methadone, tramadol. So immunoassays are better at detecting opiates. So basically, the more kind of closer to the naturally derived opioids like morphine and codeine, those will be picked up more reliably with just your general opioid drug screen. Things like fentanyl, tramadol, they most likely will not show up. And then the semi-synthetic drugs, you know, might show up, but maybe only like 50% of the time. So definitely not reliable when you're specifically looking for like oxycodone, for example. A lot of labs have additional immunoassays for specific drugs like methadone for the heroin metabolite. So you can always ask your lab if they can add that on if you're looking for a specific substance. Fentanyl is one that is becoming kind of more important for reasons I'll talk about in a few minutes. The opioid toxidrome, most of you are probably familiar with that. So CNS and respiratory depression, meiosis or pinpoint pupils, decreased bowel sounds, and then in severe toxicity, we can see hypotension and bradycardia as well. The antidote for opioid toxicity is naloxone. Our goal here is to reverse respiratory depression. So if we're in a situation where doses can be titrated, that's ideal, especially for patients with chronic opioid use, as naloxone is life-safe, is life-saving but can induce withdrawal for patients. So opioid withdrawal is generally not life-threatening, but it is of course very, very uncomfortable for patients, and can result in needing to treat the withdrawal after giving the naloxone. So naloxone can be administered many different routes, so IV, IO, intramuscular, intranasally. There's a photo of a nasal spray that is now commonly available for everyone to have on hand to use in the community. The kits there are on the lower left-hand side. This requires intramuscular administration, so that the nasal spray is much more common now. And then intramuscular doses are given as 2 milligrams to either adults or children. Intranasal doses are given as 1 to 2 milligrams for adults and children. And then IV, you can really use the lower dosing and titrate up as are on the slides there. So naloxone is an opioid receptor antagonist. When an opioid is attached to the opioid receptor, naloxone kicks the opioid off so it can block the receptor. So pretty straightforward. After administering Narcan, it's important to monitor the patient until that dose wears off, as many opioids have longer half-lives than naloxone, even with street drugs, as we'll talk about more. So the half-life of naloxone is about 30 minutes. So after a standard dose of 0.4 to 2 milligrams, it'll take about 4 to 6 hours for that dose to wear off. We do monitor buprenorphine ingestions longer because of its unique mechanism. And if a patient requires more than a couple doses of naloxone, and for drugs with longer half-lives, it is reasonable to start an infusion. You can start the infusion at 2/3 of the response dose in milligrams per hour. For example, if a patient requires 4 milligrams of naloxone to reverse their respiratory depression, you would start the infusion at 2.5 milligrams per hour. And then you can easily titrate that, just with the goal of adequate respirations ideally without inducing withdrawal. So it can be kind of a something to titrate and to achieve that. So there are some opioids with special considerations that I like to mention, just because these are ones we see pretty commonly. These are not solely opioid receptor agonists. So tramadol is actually structurally a serotonin norepinephrine reuptake inhibitor. So we can see serotonergic toxicity and seizures in overdose, in addition to the CNS and respiratory depression. So we would treat the opioid toxidrome with naloxone, and then the seizures and serotonin toxicity with benzodiazepines. Methadone, it has a very long half-life. So most of the time, if we see an overdose of this requiring naloxone, it'll result in the patient being on an infusion. And then it also does have some potassium channel blockade. So getting an EKG looking for QTC prolongation is a good idea. Buprenorphine does have this mixed receptor activity. So symptoms can, one, be delayed, and they can also wax and wane. So it's a partial agonist and antagonist, which is really nice when it's used clinically for medication-assisted treatment, but it can result in some, issues, like if a little kid gets into the tablets or the strips, then we'll need to watch them for 12 hours, just because we can see symptoms that are, they might have some nausea or be a little drowsy, and then they might seem better, and then they might get worse later on. Loperamide is a drug you might not necessarily initially think of as an opioid, but that is how it works. It's a weak opioid agonist, and that's how it stops diarrhea. This is something that's more commonly used to kind of self-manage withdrawal symptoms. I would say most people don't tend to abuse this to get high, but just to kind of manage symptoms at home if they don't want to come in and seek treatment yet for their addiction. Unfortunately, with chronic use or abuse, it can cause QTC prolongation and QRS widening. So this is when we've seen patients come in after using 80 to 100 or more milligrams per day. So much, much higher doses than obviously the over-the-counter dosing. And, this is much higher doses than were ever studied for therapeutic use. So it's a little unclear why this happens, but if you have a patient that comes in with, new dysrhythmia or an EKG that looks like this, it might be helpful to ask about loperamide use. So let's talk specifically about heroin. So we continue to see more and more unintentional deaths from heroin use. And usually in those cases, fentanyl and other synthetic opioids are involved. So you might be wondering, well, why put fentanyl in heroin? So it does have a longer half-life, so it results in a longer high. I was surprised to learn it's actually much cheaper to make per kilo than heroin. So that's, of course, appealing to the people that are manufacturing and selling it. But this also leads to more unpredictability. So we can have other synthetic opioids, not just fentanyl. This won't be detected on most hospital drug screens. If you're seeing a patient that said they used heroin and maybe required a lot more naloxone than you expected or having longer duration of effects, you might not be able to identify the exact cause just with a basic drug screen. And heroin is almost never just heroin anymore. So patients, can use the same amount they normally do, but it can be from a new batch or from a new dealer. So they might have more fentanyl or another opioid mixed in. And unfortunately, this can lead to overdoses. So be cognizant of new trend information. This is why we actually, request that opioid cases are reported to the poison center so we can kind of look for trends. Even if you know how to manage it, just a quick call to us if you have time, it is always appreciated. Other trends we've seen recently with street drugs are counterfeit tablets that closely resemble the prescription version with different ingredients. So for example, patients can say they bought street Xanax and come in opioid toxic because these tablets actually contain fentanyl. And there's a picture there of a Xanax that's counterfeit. And it looks pretty, especially the naked eye, looks pretty close to the prescription version. So pill presses are actually pretty cheap to buy. And the major difference in the counterfeit versions, besides, of course, that they contain things that they aren't supposed to, are the lack of excipients that are in a prescription version. So, for example, if you took a legitimate prescription oxycodone 30 milligram tablet and if you press down on it with your finger, it would remain intact because of all the excipients and other things in there. But with the fentanyl-based street versions, they might just quickly turn to powder, which patients actually can find beneficial because then they can snort it or inject it instead of swallowing it. And it makes it a little bit easier to abuse in that way. And I should just mention too, so other names for the blue tablets are Perk 30s. We've heard of a lot of patients just calling it Percocet, and then they come in, need a lot more naloxone than we'd expect. And they basically just have fentanyl in them. Another thing we've heard about a lot, especially in the last couple of years, is kratom, which is a plant. It's a tree in the coffee family, and you can easily purchase it online as like a unregulated herbal supplement. So it has these really interesting dose-dependent effects. So in lower doses, like less than 5 grams, this results in more stimulant toxicity. So like tachycardia, hypertension, agitation. And then in medium to high doses, so above 5 grams, it can result in opioid toxicity. So interestingly, a lot of patients actually, I would say similar to loperamide, start using this kind of to self-manage withdrawal symptoms if they don't want to come in, and then can become addicted to the kratom itself, which causes pretty severe withdrawal for patients that start using high doses of this every day. The management of addiction for this is not really well established. There's been a couple of cases of patients having seizures after withdrawing from kratom. So it might actually be a bit more concerning than just our standard opioid withdrawal, but we don't really know yet, or like the best way, like does medication assisted treatment work for this or not? So we usually recommend addiction medicine getting involved if you have that resource available. So moving on to some pathomimetics. This is a pretty huge category of drugs. So we have our prescription and over-the-counter drugs. So amphetamine or Adderall, pseudoephedrine, phentermine. And then we have more of the designer amphetamines that might be found in street drugs. So like MDMA, the 2C drugs, cathinones. Of course, cocaine is included in this category, PCP, caffeine is a stimulant, of course, and bupropion. So urine drug screens, the amphetamine one is sort of riddled with a lot of false positives. There's a lot of cross-reactivity. So the amphetamine immunoassay might pick up bupropion, aripiprazole, pseudoephedrine, ranitidine even. So it's not super helpful all the time. The cocaine immunoassay is actually pretty good though. It's actually one of the most accurate immunoassays. It screens for the active metabolite of cocaine, which is a pretty specific structure. So false positive for the cocaine urine drug screen is pretty uncommon. A TOC is not complete without at least one side with structures on it. So this is just to demonstrate the similarity between 3 different drugs. So the upper left-hand corner is meth. The upper right-hand corner is actually bupropion. And then the lower structure is a cathinone. So very, very similar structures. The toxidrome is there. So agitation, agitated delirium, paranoia, and then vital sign wise, we see tachycardia, hypertension, dilated pupils. Usually patients are pretty sweaty. We can see seizures, and then hyperthermia is bolded. That's generally what is immediate life-threatening. So, patients end up cooking all their proteins and we see multi-organ dysfunction. Some pathomimetic drugs inhibit the reuptake of catecholamine. So mostly dopamine and norepinephrine. So we get this initial sympathetic response and then eventual depletion. And we can see some serotonergic effects with many of these as well. Amphetamines are really well absorbed by all routes, so orally, by smoking, using IV, snorting, rectal. So meth specifically causes paranoia about bugs crawling on the skin. So patients can have these secondary infections from skin picking or from the practice of skin popping, which is when people inject drugs into the skin to achieve slower absorption. This can be seen too with opioids. It's not specific to that, but just something to keep in mind. These patients might have some additional kind of secondary issues to manage. So monitoring wise for these patients, we want to monitor kind of basic stuff. So vital signs, we do want a core temperature specifically especially for symptomatic patients. So rectal is going to be, the easiest for patients that are not intubated, but if you have an intubated patient, any core temperature, including bladder, esophageal is good. We've seen a handful of patients that are kind of mildly symptomatic with normal temporal or oral temperatures that actually end up having an elevated rectal temperature that required treatment. So the labs here are pretty basic, just a metabolic panel, a CK, looking for rhabdo, lactate, and then blood gases. Treatment is basically lots of benzos. So for adults, I recommend starting at 2 milligrams of lorazepam or 4 milligrams of midazolam, and then repeating those doses as often as every 15 minutes until the symptoms are controlled. Um, if symptoms are refractory to as needed benzos, patients sometimes need to be intubated for continuous sedation with propofol or benzos, or a combination of propofol and benzos. Hyperthermia should be pretty aggressively treated with evaporative cooling measures. So for EMS, we recommend like packing ice packs at the groin and armpits. And then the hospital, the best way to accomplish this is to use towels or sheets dunked in ice water and then place sequentially on the patient head to toe, then repeating that process until the body temperature is normal. A recent study found the most effective way to lower a patient's body temperature if they're hyperthermic is to put them in a body bag full of ice. This is probably not readily available, so just the towels and sheets and ice water work well. We do not recommend the post-cardiac arrest cooling catheters in this situation. Those are designed to kind of slowly reduce the body temperature over a period of several hours. So this is not our goal here. We want to achieve this as quickly as possible. So it's nice in theory, but it just works too slowly, and it's, we're trying to get it under control way more quickly than that. And also because hyperthermia is secondary to psychomotor agitation, intubated patients can be paralyzed to control their temperature if heavy sedation is not adequate. It is always a good idea to get an EEG to monitor for subclinical seizures in patients on a paralytic. And then first line for treating hypertension is benzos, but if severe hypertension develops and you're concerned for end organ damage, you could consider adding on a short-acting vasodilator such as nitroprusside to manage this. Cocaine is derived from cocoa leaves and was the first local anesthetic to be used clinically. So in addition to reuptake of endogenous catecholamines, it does have direct cardiotoxicity by inhibiting sodium channels. So if you get an EKG and there's QRS widening, we usually use 120 milliseconds as a cutoff. You would treat that with sodium bicarbolases to overcome that sodium channel blockade. And then, well, we have some pathomimetic effects increasing myocardial oxygen demand. Cocaine also has alpha adrenergic mediated vasoconstriction that limits blood flow, which can result in MI. Another thing specific to cocaine is a common adulterant called levamisole. It's an old vet dewormer and happens to be another white powder, so hence why it's used as a cutting agent. So effects from chronic use can be things like vasculitis, leukopenia, neutropenia, agranulocytosis, and then as a reminder, the cocaine immunoassay is usually pretty reliable, but it only shows up in the urine for up to 72 hours after use. Levamisole has a short detection period as well. So if there's clinical suspicion for this, for levamisole toxicity, it's good to get hematology involved to help manage that. And there's a picture of the vasculitis. You can see it. Commonly it's in the ears or nose of the patient. So bupropion is a sympathomimetic, even though it's a prescription. So it's, I'm sure you know, it's commonly prescribed as an antidepressant. It's an inhibitor of norepinephrine and dopamine reuptake, and probably some weak inhibition of serotonin reuptake as well. It lacks the sexual side effects associated with SSRIs and has other indications such as smoking cessation, so it's just become a very popular drug. There are lots of different formulations, so there's immediate release, sustained release, and XL formulations. We most commonly see the XL since that's the one that's designed to slowly be absorbed, and it only needs to be taken once a day. Unfortunately for us, that means that overdoses, we can see pretty delayed effects. And so we need to monitor patients for 16 to 24 hours kind of at a minimum, even if they're asymptomatic initially. The reason we include this as a, sorry about that. The reason we include this as a drug of abuse is because it is actually pretty commonly abused. So because it is very similar to meth or a cathinone, patients know that you can crush these, snort them, and get an effect similar to meth. We really commonly see seizures. So that is something that we kind of expect to see in overdoses, or even if someone is using this recreationally. So at the Poison Center, we refer patients into the hospital for monitoring with doses more than 600 milligrams for adults. And then the referral for pediatric patients is more than 10 milligrams per kilo. So if you think of a 300 milligram tablet, this is often only one tablet. So I include this in my small list of one pill can kill medications for kids getting into them. The clinical manifestations of this overdose are very similar to meth or cathinones, but again, with seizures being common. And then massive ingestions of several grams, we can see hypotension, QRS and QTC prolongation, leading to dysrhythmias. And then in some cases, patients have required ECMO for survival. And then interestingly, massive ingestions can also cause prolonged coma that mimics brain death. So something to keep in mind in patients that present like that. Okay, now moving on to body stuffers. Just to make a mention of this, because we see this every day, multiple times a day. So body stuffers are patients that are brought into the ED after swallowing drugs to avoid drug possession charges while being arrested. So this is in contrast with body packers who swallow usually well-packaged drugs with the intent of transporting them and coming out intact later to sell. So in our states that we cover, Minnesota and the Dakotas, we mostly see stuffers. So drugs can be swallowed in plastic baggies, wrapped in toilet paper or foil, or really whatever is available to the patient, like in their car or in their pocket. The amounts can vary, but it's usually someone's entire stash, so more than someone would use for a typical dose. So we can see potentially life-threatening amounts, like several grams being swallowed. So we recommend observing patients for 6 hours for heroin or cocaine, ingestions like this that are packaged, or 8 hours for meth. And then if a patient comes in within the first couple of hours, you can consider giving them activated charcoal. So moving on to cannabinoids, just to review the kinetics. So when cannabis is smoked, it peaks very quickly within minutes, and the duration is pretty short, just a couple hours. When it's ingested, however, it obviously needs to be absorbed and all that good stuff. So the peak can be 2 to 4 hours. The duration can be 12 hours, sometimes even longer, because of, depending on the dose. And then we see higher concentrations of the active metabolite with ingestion. So, that's why we can see the more prolonged duration of effects. So these days there are options too for much more concentrated THC. So while people can get into trouble with the edibles, just if they're, eat an edible, they don't feel an effect half an hour later, so they kind of dose stack, and then it hits them 4 hours later, and then, they just get too much. Or of course, when we have kids get into like cookies or candy and get a big dose without thinking that they're just sneaking a snack. We also have these other really concentrated types of cannabis. So even the plant itself can have much higher THC content than many decades ago. But aside from people needing much less to get high from these substances, there are other issues with inhaling. So like the vape-associated lung injury, there's a growing concern for this back in 2019. So patients were kind of presenting with these nonspecific systemic and respiratory symptoms. The cause isn't super well understood, but it's thought to be from the additive vitamin E acetate used to change the viscosity of the vaping fluid. But a lot of those patients were using illicit cartridges kind of filled in someone's basement randomly. So, you know, there could have been other stuff in there too. As far as effects, usually not anything life-threatening. You know, a lot of patients are just kind of sleepy, euphoric, can have decreased motor coordination. In kids, more specifically, we can see, especially in those bigger doses, more significant CNS depression or agitation, just because they, you know, feel weird and don't know why. Dilated pupils, kids can be kind of floppy and hypotonic and tend to have a lot of vomiting. So, you know, the airway might potentially be a concern. Treatment is primarily supportive care, and then we would treat agitation with benzos. The plant itself has many different chemicals in it, but the primary active compound is THC. So it just stimulates cannabinoid receptors throughout the body. Cyclic vomiting syndrome is an interesting syndrome that can happen with chronic heavy cannabis use. It's odd because most people associate marijuana with helping with nausea. So it's unclear why some people develop this. Symptoms are often refractory to commonly used antiemetics. Patients report that really hot showers can temporarily help with symptoms. So a study a few years back looked at using capsaicin cream on patients' abdomens to relieve symptoms with kind of variable success. So pretty little downside to trying this, but it's not a common thing to stock in inpatient pharmacies, and it doesn't work super quickly. So in recent years, it seems like things that might be better options if the patient is symptomatic enough to present to the ED would be like IV olanzapine, haloperidol or droperidol. And, you know, these can really help with symptom relief with even just one dose. So there's always new stuff coming out in drugs of abuse. So over the last few months, we've been hearing about Delta-8 THC. This is sold at CBD shops. It's not regulated federally since it's different from Delta-9 THC, which is what we think of as the THC like common in marijuana. But Delta-8 can be extracted and concentrated from the CBD in the hemp plant. So there's this kind of regulatory loophole. So, you know, synthesizing this into its final form obviously puts the legality into question. So probably more to come on that. But for now, you can buy it pretty easily. So this can be appealing to people looking for a quote legal high, younger, you know, young people. It's available in different forms, so vape forms, gummies, and it's probably less psychoactive than Delta-9, but patients have been symptomatic enough to come in. So patients, what we've seen so far are things like, you know, tachycardia and paranoia. And then this might show up as THC on a drug screen because of the similarities in the structure. But kind of the bottom line is with all this new stuff coming out, just consider different derivatives like Delta-8 THC in patients that report CBD use or buying something legally, but then they have symptoms similar to marijuana use, and then just treat that symptomatically like you would otherwise. So synthetic cannabinoids are totally different. These are chemicals that are made in labs that are essentially just sprayed on dried plant material. So with all the different derivatives, law enforcement is often behind in identification. So by the time they figure out which compound is responsible for a cluster of cases and make it illegal to sell, there's usually a new compound already being circulated. So altering these compounds results in very different effects. So it's frustrating for us because there is no clear toxidrome. We've seen patients, I would say most commonly this causes agitated delirium, even seizures, acute kidney injury, and rhabdo. But there have been clusters of patients that have had like dilated pupils, but have been drowsy and bradycardic. So it really can be really anything. And if you're wondering why someone would use this, well, it doesn't show up in a drug screen because these are all, those random compounds. So they would not cross react with the THC compound. So that's why people buy these. And then they're also can be sold as not for human consumption in these little packets as potpourri. So pretty easy to buy online or find loopholes around selling it. So drug screens for THC can stay positive for a really long time, just depending on the use pattern. False positives, things like dronabinol, proton pump inhibitors, depending on the assay. False negatives are usually things that people would try to add to their urine to make it a negative. So things like bleach, lemon juice, just really diluting the sample. I think most labs are, good at picking up on these things now. But the key thing around your urine drug screens is that if you have a patient that you're concerned for synthetic cannabinoid like K2, it would not show up on here. So to go over a few hallucinogens, LSD first synthesized in the 1930s. Like a lot of drugs, it's actually found naturally in morning glory and Hawaiian baby woodrose seeds. There's a lot of different hypotheses on the exact mechanism, but the symptoms are likely related to serotonin excess and NMDA antagonism. So serotonin excess would be things like agitation, tremors, clonus, tachycardia, hypertension. And then NMDA is more like dissociation and hallucinations. So just like how heroin is usually not just heroin, street drugs sold as LSD can have meth or synthetic cathinones in them. So unfortunately, it's, a lot of these things are contaminated and people end up using things that they weren't intending to use. PCP is a dissociative anesthetic, so similar to ketamine. It inhibits reuptake of norepinephrine, epinephrine, serotonin, and then also inhibits NMDA receptors, which is responsible for the disinhibition that patients can have. So that also causes the rotary nystagmus. So these patients can be dangerous to themselves or to, people trying to care for them, just because they can be totally disinhibited from pain. So like I've heard stories of patients breaking their own arms, getting out of restraints just because they can't at the moment feel any pain and can be pretty agitated. So management, just like the sympathomimetic toxidrome, quiet dark rooms, benzos, lots of benzos, and then in severe cases, intubation, sedation, ice for hyperthermia, all of that we already talked about. So psilocybin or shrooms, these are heat stable toxins, meaning if you were to cook them, it would not degrade the toxin. The thought is also that this results primarily in serotonergic excess, and these things are eaten or made into a tea. Generally, we see dilated pupils, a lot of nausea, vomiting with these, hallucinations, which is, why people want to use them in the first place. I'm not sure of the mechanism behind this, but some people can have flashbacks like weeks to months later of sounds like usually bad trips after using shrooms, even just once, which sounds pretty horrific. And then the treatment is just supportive. So quiet, dark rooms, reassurance, maybe benzos if they're having a ton of nausea, vomiting, or if they're agitated. Robotripping is something that we see pretty commonly. Dextromethorphan containing cough medicines. They're pretty easy to buy. We do see dissociative effects, so similar to like ketamine or PCP, but obviously to a lesser degree. But you can find these different dosing charts online for which plateau you want to get to. So you can even find like weight-based dosing charts if you want to get to like the 4th plateau, which is like total out-of-body sensations. I just picked a random chart that I found online for an example. And then the treatment for this is supportive and symptomatic. A lot of times there are co-formulations with antihistamines. So we can see anticholinergic toxicity. So patients can be more have like picking behavior, urinary retention, really dry, or they can look more serotonergic and dissociated. So would just treat that, with the predominating toxidrome there. And I recommend getting an acetaminophen level just because a lot of these formulations can have acetaminophen in it as well. So just not to miss that. And then I'm just going to briefly talk about huffing. There are a lot of different things that people can huff. So we don't have time to talk about all of them. But commonly fluorinated hydrocarbons. So that's like what's in the keyboard duster. These are really highly lipophilic compounds. And when you inhale them, it causes rapid onset euphoria and CNS depression. And then they have a really short half-life. They also can act as an asphyxiant, so just cause oxygen displacement, which can cause people to have syncopal episodes. One of our more common calls is if someone is huffing in like a public bathroom, someone sees them have a syncopal episode, and then they get brought in by ambulance. And usually by the time they're in the ED, they are back to baseline. What's dangerous about this is that huffing these can sensitize the myocardium to catecholamines. And there's actually a specific syndrome named after this, sudden sniffing death syndrome. And this is what happens when someone who is huffing gets a catecholamine surge. So like when a teenager is doing this in the room and the parent comes in and yells at them or scares them, and then this can lead to ventricular dysrhythmias like VTAC or VFib. And this is a larger concern pre-hospital because of the short half-life. So usually this happens like when someone is actively huffing and this happens. Also, if you have ever held down a can with this propellant in there, it gets really cold, so patients can get frostbite injury to like their mouth or mucous membranes, depending on how how they're huffing it. So take-home points. Using toxidromes to identify a group of symptoms can help with the general treatment approach, especially if you have an unclear history. Often street drugs are not as advertised, so even a patient might insist that they use meth, and they might come in looking opioid toxic. A lot of these things can be cross-contaminated, so treat the patient, not the history. Urine drug screens are not clinically useful most of the time to manage symptoms, but can be helpful in just identifying a specific exposure, especially in a child or when there's a broad differential diagnosis in a complicated patient. calling your lab, or we have a great toxicology lab at Hennepin Healthcare, our great resource for these urine drug screening questions. And then, of course, call the Poison Center for assistance in managing poison patients. And that's why we're there. So have a few references, and I'd be happy to take any questions.
Awesome. Thank you so much, Becca.
Thank you.